Greetings, everyone. Welcome to ONC's fourth Tech Forum. It's hard to believe we're up to that many, but time flies when you're solving interoperability challenges, coordinating standards development, connecting networks, giving patients greater ease of access to their health information, enhancing clinical workflow, addressing information blocking, issuing new regulations, revising the next 5-year federal health IT strategic plan, developing a trusted exchange framework and common agreement, and so much more. Now, I said this was the fourth Tech Forum, but technically it's the first. We're continuing the tradition of the Interoperability Forum, but with a bit of a rebranding to distinguish this 2-day event from the ONC annual meeting. As a result, you'll see a stronger emphasis on the role and intersection of all things tech when it comes to interoperability. So welcome again to the Tech Forum. Typically, we consult the Farmer's Almanac and find the hottest, most humid days in August to hold the Tech Forum. That way, we ensure everyone in attendance can get a true DC experience. Obviously, like many other convenings, we've gone virtual this year. So while I'll definitely miss testing out my ninja skills in the halls to avoid your tough questions, we've lined up a jam-packed set of tracks for you throughout the entire Tech Forum and experts with whom you can engage. Our staff across ONC have done a tremendous job creating a virtual conference experience and recruiting top-notch speakers. I want to say thank you to all of them and to all of our great speakers. The transition to virtual conferences is hard. And as your host and usual MC, it's my job to help. I've prepared Steve's 7 tips for making your virtual conference feel like the real thing. Number 1. Turn down your AC as low as it can go. We all know it's typically super cold in these conference centers, so it's important to make your surroundings as real as possible. Number 2, change your Wi-Fi password. Write it on a tiny slip of paper and tape it up in a random hallway or room. The Wi-Fi password scavenger hunt is a rite of passage at any conference. Number 3, give everyone in your house a name badge. Everybody, significant other, kids, pets, you name it. Number 4, make a pot of decaf coffee before you sit down for the first session. And when you get up for a break, complain that all that's left is decaf coffee. Number 5, when you have a burning question that's really a comment, pop it in the chat. Number 6, tchotchkes. Anyone who's attended a conference or two knows that you never go home empty-handed. Google at-home origami during a break and make yourself something with your company logo on it. Number 7, we all know that your next session is always inevitably on the opposite side of the conference hall. So between sessions, get up, walk down the block, turn around, and head back to the computer. There you have it, folks. You're well on your way to an authentic in-person conference experience. If you've got more tips, you can find me on Twitter. When we were closing out 2019, I don't think any of us would have predicted everything that's happened in our industry. Some things, like telehealth, have moved at light speed. Our public health infrastructure is being flexed and reshaped in real time, and the initiatives and activities that we have collectively worked on over the past decade have had their mettle tested. But we know that among the bright spots, this pandemic has shed light on parts of the health IT ecosystem that still needs work. And that's why all of us show up year after year at this event and others. We know there's more to do, and in the face of the challenging times that lie ahead, we are here to make a difference, to drive change, to make healthcare better. If there's one thing that bears repeating, it's how deeply interconnected our work in healthcare is. We need to blend so many different dimensions together: technical, policy, state and federal law, privacy, security, financial, administrative, the patient experience, caregiving, innovation, health and digital literacy, social determinants, compassion. I could go on. As you engage with your colleagues the next 2 days, think about the expertise you bring, what you have to offer, and equally, what you'd like to learn more about. Thank you for attending ONC's 4th Annual Tech Forum. A few quick logistical notes. Yes, all the sessions will be recorded and posted to healthit.gov. And you'll have access to this virtual platform for the next 60 days to rewatch all the sessions. This morning, we'll have 2 plenary sessions, and after lunch, we'll gather for working sessions across 4 tracks: Content Exchange Standards, Technical Framework for Trusted Exchange, API Standards and Innovation, and Tech in Continuum of Care. Make sure to stop by the networking lounge during breaks where you can chat with one another, or join an Ask Me Anything chat with members of the ONC team. And make sure you stop into the exhibit hall to check out health IT projects our stakeholders are working on with ONC. Now, it's my pleasure to kick off our first plenary session, a fireside chat with the National Coordinator between Dr. Don Rucker, National Coordinator, and Denise Hines, Chief Americas Officer at HIMSS. Dr. Hines has more than 2 decades of healthcare experience in a variety of settings. Dr. Hines recently was a member of the HIMSS Board of Directors, is the past president of the HIMSS Georgia chapter, and in 2017, she was recognized with the prestigious Women of the Year in Technology Small Enterprise Award from Georgia's Women in Technology. Denise interviewed Don at HIMSS during the beginning of his tenure, and it's fitting that she is here to chat with him today. The only thing that would make this better would be if they were actually sitting in easy chairs with crocheted blankets on. Over to you, Denise and Don.
Hi, Denise.
Hi, good morning, Don. How are you?
I am fine. Going through a little bit of interesting telecom issues here with our ambitious platform, but looking forward to talking with you.
Yes.
So why don't I guess we just get started?
Why don't we do that? So I will kick it off with several questions for you. I promise I won't be too tough on you.
All right. Tough is good. Tough is good, actually. A lot of devil in the details stuff and everything.
Oh yeah.
So.
Oh yeah. Well, perfect. Okay. Well, as you know, HIMSS has been one of the organizations that have been actively supporting and encouraging ONC. And originally I was going to say pushing ONC, but I'll say strongly encouraging ONC to release the final interoperability regulations as quickly as possible or as timely as possible. And we know this was a huge success for ONC and a big accomplishment for not only ONC, but also the federal government. So, Don, why don't you give us an update about where we are with implementation of the rules and what the federal government is looking for?
Yeah, thanks, Denise. Well, first of all, thanks to HIMSS for everything you do in moving the entire community forward, and all the work on fit and finish and getting information technology out that HIMSS has been doing for literally decades. I know as a regular HIMSS attendee for many, if not most of those decades, greatly appreciated. So the rule, as folks on this audience probably know, posted in the Federal Register in the beginning of May, which is the formal starting point, and we have put in some what's called administrative discretion to delay a number of the provisions due to COVID. So that has obviously impacted things a little bit. You know, it's interesting when you think about it. If, let's say, this rule had come out 3 or 4 years ago and all these APIs were up, our ability to deal with a pandemic would actually be materially different and much better as we look at telehealth and remote and patient engagement and patient empowerment. But you know, we are where we are today, and so the 3 big let me tell you about each of the 3 big provisions in cures. So the first provision is information blocking, right? So this is the concept that patients really have an absolute right to their information and an absolute right to their information electronically, and that should not be, if you will, hidden away because of commercial interests. And when you look at that, I think first of all, people are really getting a good understanding that that's the case, and there are a lot of folks who are, have really opened up things. The final rulemaking from the federal government on how to enforce it, that's the Office of the Inspector General. That part of it is not. That part of it is still a work in progress. So there's not immediately. There's not immediately a enforcement mechanism, and we also are working on the rules related to providers. There's a different set of penalties for networks, exchanges, and then EHR vendors and providers. But I think we're making good progress there. So that's one part. The FHIR application programming interfaces. So the second part of Cures is the concept that Congress put in, and President Obama signed and President Trump strongly supports, which is that application programming interfaces should be without special effort, right? So what is the test of that? Well, really the test of that is once you've logged on, obviously you have to log on because this is your private, secure medical information, but once you log on, you should have that consumer ease of, let's say, an embedded map in a smartphone application. And in the modern world, a lot of this is really about the use of FHIR, and you'll hear this throughout the tech forum. So, I think you'll see a lot there. And then finally, the third part, the Trusted Exchange Framework Common Agreement. We've issued a contract to Sequoia Group. They're hard at work on putting this common agreement together. So I think we're seeing some very good progress on all of the key parts of the 21st Century Cures Act, as Congress intended. So, yeah.
So how will we know if the regulations, policies, if the objectives have been achieved? What will you look for?
I think we'll really know it, when we have an app economy where apps can actually use a patient's medical information in a way that is widespread and convenient. And clearly there is some work in progress because right now we're using the OAuth 2 authentication, and so you have to log on. There are a lot of authentication technologies that are moving along rapidly. So I think in the next couple of years we will see, true consumer security, and of course with all of the privacy protections that authentication brings. So I think that widespread app use will be the first and foremost proof statement that the intent of Congress and both parties has been met.
So let's talk a little bit about the patient experience. How do you see the patient experience changing, particularly with the increased use of APIs in health information technology?
Yeah, the patient experience in medicine, I think, anybody who's had the, misfortune of being sick, certainly, and even folks just sort of a more routine visit and contact with a health care experience, I think we all know it's a cumbersome experience. It's cumbersome from the payment point of view. It's cumbersome from the provision of cure point of view. It's cumbersome from transparency in what's being done. It's cumbersome from a just convenience of things like making appointments. It's just every step of the way for most folks, most of the time. There are some exceptions, but for most folks, most of the time, there's a lot of stickiness. The beauty of, and that stickiness reflects manual processes. The beauty of application programming interfaces is that those things can be automated real time. So that stickiness goes away. And I think as time happens, it will, at every point of the way, become a much more seamless experience. I mean, we've seen in a different medium where security is a huge issue, maybe even arguably a bigger issue than in healthcare, which is in financial payments. We, we've created a fairly virtual, fairly robust world. A lot of the authentication security is really embedded and behind the scenes. I literally, in my wallet, I don't think I've opened my wallet other than take out a credit card literally in months to pay in cash. If you had said, 30 or 40 years ago, you're going to live in a world where, you don't need cash, we would have been, that's interesting. So that's, I think, where we want to be in healthcare. The Cures Act and the work of this meeting really, I think, moves that along quite a bit.
That's interesting. You mentioned that over my last couple of doctor's appointments with the pandemic, they're now encouraging payments online when you pre-register credit card information online, so that
interesting.
cash
Yeah.
is not accepted at the registration desk.
Yeah,
So
interesting.
Already. So why don't we talk a little bit about HIEs and the importance of HIEs? And we know that the state and regional HIEs are really playing a critical role in helping our health systems address this COVID-19 crisis. HIEs are aggregating and disseminating all types of data from hospitals to public health entities to get information to the providers as timely as possible in the middle of this pandemic. So what do you see the role of HIEs? I know we're going to get into an interactive discussion about HIEs, but I can start with you, or you can start with me, and we can go into this interactive discussion about HIEs and their role.
Yeah. Well, let me talk a little bit about what we're seeing. So I think there's a real opportunity. Most of the country is now covered with HIEs, health information exchanges, and they really are a good way to have central store. Some of them federate the data and the messages out to the various providers as needed as they're taking care of patients. And in that world, that can provide really one-stop shopping for providers on reporting. It's, the one-stop shopping on reporting is, I think, going to be important. We have right now, obviously, a lot of different mandated reporting because of the pandemic, but I think over time we can move to that more integrated reporting where then the public health agencies get a feed from the HIEs. We're not there yet, but I think that's a big opportunity. The one thing that we've noticed is for a lot of questions, the HIEs have longitudinal data. So the longitudinal data is really very powerful to answer a set of clinical questions that goes beyond things like how many tests were done or how many people are in an ICU. The longitudinal data can answer questions like, what's the time course from when somebody turns positive to when the test turns negative, or the time courses and the curve, the shape of the curve over the population when folks turn positive to when they develop immunity. What is the rate of reinfection? What are associated complications? So I think there's some very powerful things that are possible in this HIE world. But I'm very curious. So you ran the Georgia HIE, and I think we're involved in its start. So what's your take, Denise, on all of this?
Well, I'll start with saying that, HIEs have really been involved in these types of crises over the time periods, particularly when we see patients who are I guess, removed from their normal or their provider circle. So HIEs have been involved in providing data during hurricanes and wildfires and some natural disasters, and we've played a critical role to exchange information. So during this pandemic, we see where the need to exchange test results has, and aggregating and reporting those test results to from public health district labs to independent labs to healthcare providers, and as you mentioned, ensuring that that care record is available. So HIEs are able to bring together not only the lab results from these disparate sources, but also bring in the care records. So allowing the epidemiologist to take a look at the full health of the patient, particularly when we need to know about comorbidities in this instance. So HIEs can aggregate the data from bringing in the symptoms to comorbidities reporting, can bring in the test results from not only just the positive, but also the negative test results. HIEs are being asked to report those. The demographic reporting, the normalization of coding, meaning when you're getting data from disparate sources, HIEs are experienced with technical resources to normalize the data to make sure it makes sense when we're exchanging it to different sources that may not be able to accept the original data set. But also what HIEs have been able to do, not only through this COVID experience, but in full existence, exchange information from the most sophisticated health systems to those community services that may not have robust EHRs. So the HIEs can provide tools and resources or even dashboards or access to tools that allow all types of providers to exchange information as needed at the right time for the right patient. We're now seeing where HIEs are creating dashboards that can not only track healthcare facilities, but also bed utilization. We see how important that type of information is. We're also seeing where HIEs are asked to provide information to emergency management systems or services so they can be prepared as they respond to help through this healthcare crisis in their protective equipment ready to go. So more information to the right providers at the right time has been the role of HIEs, and we see that role growing in importance over and over again as we prepare for getting our society ready for to be as responsive as possible for natural disasters and pandemics, epidemics, and that's been the role of HIEs, exchanging data and facilitating information for our frontline staff. So, Dot, I know ONC has been really encouraging the use of HIEs through your tenure here, and all of the rules include the use of making sure that HIEs are included as the place to go for these types of purposes. So maybe you can talk a little bit more about what you see the future of HIEs and how the role of HIEs will continue to grow through the next several years.
Yeah, I think you're spot on there. So what we're going to see, I think, is that the state and the local HIEs are interesting because they have you can sort of think of them as the last mile, if you will, in terms of connectivity. So they really go beyond our sort of current EMR-based thinking about connectivity, and that's obviously where we had to start. To we see them eventually over time having a lot of other clinical type resources in the community. So this includes things like group homes, shelters, social determinants of health on the one hand. That some of these resources, and in some areas, San Diego, for example, these things are already being tied in. So there's a big opportunity there, because that whole world that's sort of right at the boundary of clinical medicine and often overlaps. I've been an ER doc for 30 years, and believe me, it overlaps every shift. That world we really don't have computerized. When the patients leave that classic clinical network, then they're sort of lost, and then they come back, and we really don't know, where their illness is, the trajectory of their illness is when they're elsewhere. So I think bringing in the broader behavioral mental health resources is going to be one of the goals here. The other important thing is just they really can take bits and pieces from everywhere, and as you point out, we've seen this. So, for example, a reference lab may be able to get the lab test for COVID, but doesn't have an EMR, doesn't have any tools, doesn't have the workflows to bring in comorbidities or race and ethnicity, those types of things. The HIE, because of records over time, can combine all of those in an integrated view. So I think it's a very powerful part of the infrastructure. Again, a lot of it that the HIEs do right now is under the radar because it's between providers. So, for a lot of folks, they may not be aware of the role here.
And I think it's worth talking about population health, particularly as we're seeing COVID has really highlighted the need for us to understand, as you mentioned, social determinants of health, and the role of HIEs to bring information such as race, ethnicity, employment history, recent travel history. Understanding these types of factors have been particularly highlighted through COVID-19. So I want to know from you, how do you see HIEs beginning to aggregate this data as we take on, as HIEs are taking on more data, aggregating? What are some of the tools and resources you're seeing that will need to be introduced or have been introduced to wade through these large amounts of data that HIEs can aggregate and use, but also make sure that we, HIEs, get that information timely in small enough, digestible enough information to a care provider that's useful?
Yeah, I think there are really two cases. So one is the individual care provider, which of course is the data on a patient, and they're really just the amount of connectivity is critical, right? So, and the nature of that connectivity. So if I'm a paramedic or an EMT in an ambulance picking somebody up from the scene, it would be very helpful to know if that person has COVID, or if I'm a triage nurse in an emergency department, or let's say registering somebody in the surgery center for a procedure. Again, very, very helpful to know that status. So that's the individual level. A number of the HIEs have gotten together, in part through SHIEC, their trade organization, SHIEC, and are starting to do some early aggregation of this information so we can get more of a national view longitudinally of this data. And once the data is collected, of course, you can use a very interesting set of analytic tools to help do the looking and the understanding. A differentiating factor for the HIEs over what I would call prospective reporting is the HAEs have a complete set of the data, whereas a lot of the reporting things are asking specific questions. But as our knowledge of this pandemic, or let's say a new pandemic with a totally different presentation, set of symptoms and signs arises, right, we won't know what the questions necessarily are to ask ahead of time. And because the HAEs have arguably a complete set of the data, they're going to be in a position to do, even symptoms that we didn't think were important in the past, but now in this new pandemic are. So it gives us a very interesting public health flexibility as well. Obviously, on the overall population health level, our work with the Cures Rule and FIRE, which could be used by the HIEs, can be used by everybody, can be used, in fact, will be required in several years in electronic health records, is something we're calling population-level FIRE or bulk FIRE, which will allow an entire set of data on a patient population to be analyzed. And that can be done on-site by the provider. It can be done under a HIPAA treatment payment operations signed contract between providers and payers. I throw that out just as a pitch for the next panel, since we have an awesome panel to discuss that opportunity. So thanks, Denise, for letting me slide in a plug there.
Yeah, I was doing my best to cue that up a bit because I know, first of all, I want to thank you for mentioning Chic, because Chic has been very instrumental over these last years, particularly now with COVID, of bringing HIEs together, allowing the exchange of best practices, allowing HIEs to talk to each other, to move in a way where HIEs can adopt technology faster, talk through solutions faster, to be much more responsive in situations that were, I guess, not as predictable a year ago.
Yeah.
So that's been very helpful. So why don't we shift just a bit? You've already introduced some concepts about what's coming in the future, so why don't we talk a little bit more about that? What do you see with the health IT landscape? How do you see it changing in the next 5 to 10 years? And some of the tools and challenges you see healthcare and health IT taking on that we can begin to think about addressing?
Yeah, I believe there's pent-up consumer demand for a better healthcare system. And I think we've already noticed that the public is increasingly noting how behind the times health information technology is to the technology they're just, swimming in, literally, in the rest of our lives, frankly. So I think that delta, is going to have to, that gap is going to have to close. There will be a huge pressure to close that. There will be all kinds of new opportunities. I think we're going to see in healthcare a bit of what we've seen in retail, which is there's going to be a sort of a to be determined mix of sort of what in retail is called bricks and mortars, what in healthcare are called hospitals, offices, surgery centers, urgent care centers, imaging centers, and the virtual world. The conversations will not just be largely from these sort of very simple conversations between providers and patients or back again. I think, they're going to be much richer, continuous things that go way beyond this. In healthcare, we sort of had that little walkie-talkie, one person clicks at a time and talks kind of thing. But in this instrumented world, we're going to have a lot more information. We're going to have all kinds of tools. The FIRE APIs over time, I think you will see, are going to allow rich patient-generated, patient-provided data, integrating with future electronic health records. So I think we're going to have vastly richer, more continuous conversations. Because we've had this episodic visit the doctor, visit the hospital kind of view, we haven't really capitalized at all on the fact that health ideally should be absolutely continuous, and of course has many behavioral things, which, as we all know in America, are just a challenge for many, if not all of us, on a personal level. So I think that entire health maintenance, preventative measures, increasing health, all of that instrumentation to do that is going to move along on the one hand. I think the pressure to do APIs within the delivery system for the internal provision of care is huge. We actually have a conference next month on automation, virtual conference, that we're starting some work with experts just to lay out some early steps to sort out how we can do automation in healthcare. Healthcare is a very, very manual process. Because of the payment system, we focused on EHRs as the core, but we really need to be more like process automation and factory automation to bring a lot of these values. Hospitals certainly are going to be increasingly instrumented to make this easier. Patients, smartwatches, we're going to be more instrumented in a hopefully totally seamless kind of way that will preserve our privacy. But that richer thing is, I think, going to get materially better outcomes and, frankly, at a materially lower cost to the American public.
Okay. Well, Don, we have several questions queued up.
Sure.
For you. So why don't we allow some of these audience questions? So I will ask a few here for you.
Sure.
All right. The first one is FHIR intended to replace CCDs?
Well, I look at them as, complementary. Obviously, they've had different time trajectories. I think components of the CCD will obviously, are structured, and, FHIR will be complementary to those components. Components of the CCD have more of a text nature to them. They, I believe, ultimately, all of these things will certainly, even if the components are very, very similar, will, my guess is just a guess, but over the coming years, I think a lot of these things will have FHIR wrappers, and that is based not so much on, there's a policy that says, change this on day that, but really there's an elegance to FHIR and the RESTful JSON infrastructure that FHIR rides on that just makes computing and programming a very doable experience. And I think it just means that those folks who are using those tools are going to be able to advance more rapidly. And I think that's going to be the driving force.
Our next question is about direct. The question is, direct has been mandated 5 years ago, and the question is around why isn't everyone using direct?
Well, first of all, there's a vast use of direct. Direct is exchanging, my understanding, billions of messages. So there's a widespread use of direct. Direct, for folks who don't know, is secure messaging, right? So privacy protecting messaging to sort of get this email in an authenticated way. I think one of the things we're doing to even further direct over time, you're going to see CMS in provider directories. You'll see direct addresses. So you'll see, an increasing level of ease for providers to use direct. So I think that infrastructure is going to continue because I think we need secure messages.
Yes, and just to add from the work here in Georgia with the HIE, Georgia was an early adopter of Direct, and we exchange, I think we're at nearly 1 million messages using Direct. It also creates the opportunity for long-term care, personal care homes, ambulances, and other stakeholders who have not been able to adopt advanced electronic health records. It allows them to participate in the electronic exchange of information, along with being able to participate in referrals and receiving discrete information from labs and others using Direct. So I can say we have been really a user and encourager of Direct adoption here in the state of Georgia, and really still using unique use cases, even with our public health agency setting them up with Direct so they can receive referrals through direct messages as well. So it's been quite convenient for use. Okay, let's go to another question. We just talked briefly about lab results. The question is, the results were a person has gotten their lab results or lab work done, and the results were sent to their primary care provider who stored them as PDFs. Is there or will there be any obligation for discrete lab results to be sent to a patient?
Yeah, obviously we're trying, data that's discrete data should obviously eventually, should stay as discrete data and be communicated as discrete data. The Cures rule, the initial information blocking provisions till the U.S. Core Data for Interoperability kicks in, which is, those requirements on electronic health records, which are 2 years, downstream roughly from now, modulo the COVID extension, will have, FHIR-based APIs for lab information as a requirement of the certification process. Obviously, putting things into PDFs is not that helpful for all of the obvious reasons that this audience knows. So I think you're going to see to see those types of things go away over time. That actually gets to the prior question as well, which is that the elegance of the APIs is in large part what makes this possible and accelerates this. So I think we're going to see under the Cures rule, and frankly the work that we're doing at the Tech Forum today and tomorrow, greater understanding, greater progress on jump-starting all of these things. There is already a lot of work going on FHIR. Had the FHIR Developer Conference, which now I believe was 2 months ago, the HL7 FHIR Developer had 700 attendees who are pretty much all programmers. So we're I think seeing some great progress.
Wow. Well, I know we are out of time, and I'm going to encourage the persons who submitted questions that we weren't able to get to they will be filtered throughout the day for the next session. Some of them are very technical, so I think they can be covered in the next session. So we'll make sure those get forwarded on since we are out of time. So Don, let me thank you, Dr. Rucker, for your time today. Thank you for inviting me to have this fireside chat with you. And it's been absolutely my pleasure to spend this time with you.
Denise, thank you so much, and thanks to the audience for all the great work that you do in making patient care better. Thanks.
There will now be a 30-minute break. Please return to the auditorium at 10:30 Eastern for the next session.